Welcome to this first Resilient talk. My name is Teresa Lopez. I'm cardiologist at La Paz Hospital in Madrid, Spain, and I have the pleasure of being joined by Dr. Borja Ibáñez. Borja Ibáñez is currently the coordinator of this big resilience project. He is also the director of clinical research of the National Center of Cardiovascular Research in Spain. He was trained in Spain, but also in US at Mount Sinai. And his research mainly focused on myocardial infarction, heart failure, and for sure in cancer therapy-related cardiovascular toxicities. Borja serves as PI in several multi-center trials, and also he served as the chairman of the 2017 ESC guidelines on myocardial infarction. So it's a great pleasure to be with you, Borja, today. And the main reason of this interview is to ask you, what is resilience? So what is the purpose of this big project?
Thank you very much, Teresa. So it's a real pleasure to participate with you in opening these videos. So Resilience is a European Commission funded project that is aiming to reduce the prevalence of heart failure in cancer survivors. So as you know, anthracyclines, which are extremely effective to treat many different cancer types, also can result sometimes in cardiotoxicity, and this can make the problem that patients surviving cancer, eventually they have to live with chronic heart failure. So in Resilience, we have different objectives that we can discuss during the interview, but mainly we are going to be testing a novel intervention, which is remote ischemic conditioning, that can eventually reduce the prevalence of cardiotoxicity in patients who are at risk. So also we are going to test different imaging modalities, mainly based on magnetic resonance imaging, to see whether we are able to identify cardiotoxicity. So in summary, Resilience is a patient-centered project because patients, as we can discuss, have a very important role, and we're planning to tackle the problem of cardiotoxicity mainly to develop a new intervention and also to identify early.
And what are the main challenges of the project? So to bring the project to the clinical arena, what do you think that are the main challenges you have?
Sure. So the project revolves around the execution of a randomized clinical trial in which patients who are at risk for having cardiotoxicity, these are non-Hodgkin lymphoma patients who have also a risk factor for developing cardiotoxicity, are going to be randomized to remote ischemic conditioning, which will be done by the patients themselves at home once per week. And then we are going to follow up this patient with magnetic resonance to see whether their remote ischemic conditioning prevents the reduction in cardiac function. So being a project that is revolving around a randomized clinical trial, this is a multi-layer project and in fact involves different stakeholders in the process, so from cardiologists, hematologists, industry, scientific societies, and also patients. So the main challenge most probably is to have all these parties working together to achieve the goals that are set in the project.
So in fact, it's a really huge project with a very interesting topic. And even if you are going to use a very sophisticated tool to understand if patients suffer or not any cardiovascular damage related to anthracycline, the plan of the project is to have really easy tools to apply them in daily practice that could be really useful for a standard patient, even that are treated even in a small hospital. So could you tell us a bit more about this novel intervention that is expected to reduce the prevalence of heart failure?
Sure. So within this project, and based on preclinical data that we have done within the previous years, we're going to be testing what is called remote ischemic conditioning. So remote ischemic conditioning have been tested for several decades in different areas, not in the cardiotoxicity field, but for example in fields such as myocardial infarction, stroke, cardiac surgery. And basically what this is a non-invasive intervention, which is entailed by the device that is similar to a blood pressure cuff. And the concept behind remote ischemic conditioning is that brief episodes of ischemia and reperfusion in a distant organ, for example in the arm, that is by inflating a cuff pressure for 5 minutes and then releasing the pressure for 5 additional minutes and repeating this for 4 times, then there are some protective signals that are distributed across the body. So the idea is that eventually when the heart is exposed to anthracyclines, eventually they are going to have previously received this protective signaling from the remote condition in the arm, and eventually they are going to be able to cope better with the aggression entailed by anthracyclines. So as you mentioned, this is a non-invasive tool, because eventually this is something very similar, as I mentioned, to measuring the blood pressure. And what is also very important is that the patients can do this at home. So within this project, we are proposing that the patients will have this blood pressure device at home, and they are able to implement this remote ischemic conditioning once a week for the entire period that they are going to be receiving anthracyclines.
So how do you think that this project can contribute to improve the patient's life?
Well, this is most probably the most relevant objective within this project, because in the end we are aiming in order to increase quality of life. So the patients, thanks to the development of different interventions, and in this case, the development of chemotherapy and other interventions to treat cancer, the chances for survival are much higher. But many times these patients, they have higher chances for having cardiovascular conditions in the long term. In this case, it's not only to have this cardiotoxicity that after exposure to anthracycline, the heart can have a significant reduction in the performance, but also there are other comorbidities which are associated with the consequences of having received these long-term therapies. So eventually, with our main hypothesis is that by reducing the deleterious effects that anthracyclines can perform in different organs. Of course, they are extremely effective to treat cancer, but also they can have some side effects in the heart and eventually in other organs. We are going to be able to improve the quality of life. So patients will survive cancer, hopefully, and they will survive with a quality of life that is not impaired by the downstream consequences of having received these therapies.
Yeah, so it's very interesting. In fact, probably what makes resilience unique is that you are going to work with a safe and cheap intervention to improve the cardiovascular and, in fact, the overall prognosis of our patient. And probably one more question that is more in the personal field. So what motivates you to deal with cardio-oncology? Why do you think that this topic is really relevant for patients and also for European Society of Cardiology, of course?
Well, as a clinical researcher, I'm always trying to do research that can really solve the problems of the patients, because we are not doing some research that eventually we don't know whether this would apply to patients, but rather we are first looking what are the clinical needs and then trying to do research. In this field of cardio-oncology, in which there are some leaders, in fact, you have been one of the leaders and you are the chairperson for the forthcoming guidelines for cardio-oncology. It has been identified within the previous years that there is a clear need in order to tackle the problem of cardiovascular complications in patients with cancer. So cancer and cardiovascular disease, they share common risk factors, and also the treatments that are being used to treat cancer also can have or can increase the chances for having some cardiovascular complications. So this is why we thought that eventually this was a field which has not been well developed in the past. Only in recent years all the attention of cardiologists, and in fact there is a lot of room for improvement, as we discussed before, not only to be able to increase survival, but also to increase quality of life. So the main reason why we got into this field of cardiology, as it was based on others, is trying to improve quality of life of these patients and trying to prevent them from developing cardiovascular complications, which is extremely frequent, unfortunately.
So I can't agree more with what you say. I think that resilience covers all the main aspects that we want for cardio-oncology and for our patients to improve their life and also their quality of life. So do you have any final remarks or comments?
Well, I think it's very important to highlight that resilience is a team effort, and we have the participation of different partners. So we have different institutions, academic institutions. Also, we have the European Society of Cardiology participating. We have industry. We have Philips participating in this project. And it's I would like to highlight that is the multidisciplinary and the different angles from which we are tackling this problem, what is really unique. And I think it's fair that we are highlighting that we have different stakeholders working in the process that will participate. And most probably this is going to be the only way by which we are able to be successful, by taking these different aspects and all of them working together.
So thank you very much, Borja. I think that we are all working hard to success in this project, and say good luck and thank you very much for your time.
Thank you very much, Teresa.